name is John Ellis. I am a professor in the School of Social Work over at the University of Akron, and also I do some instructor work with M4 addictions course at Neomed, and in the past have consulted a little bit with the Department of Psychiatry. Today we're going to go through SBIRT. So for those of you that don't know, it's screening, brief intervention, and referral to treatment. And it's essentially the opposite of don't ask, don't tell. And it is really, how do we, NIDA has done, it estimates that about 1 out of every 10 persons in America has a substance use disorder. The vast majority of them are undiagnosed. Undiagnosed despite they do utilize healthcare services, undiagnosed despite they might have some legal consequences. And at all the places that they stop where services might be initiated, we tend not to ask about the substance use issues. So SBIRT was developed really to, try to initiate conversations on substance use, substance abuse in medical settings. Now, about 15 years ago, there was the AMA was involved in the discussions when they were trying to get SBIRT into a billing code with CMS. And one of the concerns were after they established a billing code for it, there still wasn't a lot of billing for SBIRT. And when they talked to the medical persons, they said, it's hard for us. We already have an agenda in our sessions. Many medical sessions are only 10 to 15 minutes anyway. So to add additional, agenda into there is sometimes difficult because they're in a hospital for a different reason. So there was work done to shrink this where now a real SBIRT conversation can take place in as little as a minute and maybe average about 3 minutes, just to make it a little bit more possible to launch this in the middle of any medical visit. So we're going to go into, what is SBIRT? What's an ordinary flow of services? I'm going to emphasize a little bit of the brief negotiated interview. Because a lot of times people think, well, this is going to be a long drawn out conversation, or I'm going to get trapped into a long conversation. But the BNI is really just how to start and finish this conversation in a matter of minutes, if not sometimes moments. And if we have time, maybe even go into some motivational interviewing basics. But we do have, and I looked at the PDF of the overdose data that Dr. Ballister showed. So I think we're going to go into conversations on that instead. So with the brief negotiated interview, the definition is it's an evidence-based practice. So there is some studies done through SAMHSA. They're published on the site. I'll send you some links to those on the last slide that you can have access to. But there is a robust amount of data started by the IOM recommendations to begin to have these conversations in medical sessions. So when I get into why doctors don't have the luxury of time, and how can we go about this? And an example was about 2002, the state of Ohio, which was ODADIS at the time, the Ohio Department of Addiction, Drug and Alcohol and Addiction Services, was really looking at creating non-smoking campuses with treatment providers. And they knew this was going to be a big issue, and they found that persons that do smoke cigarettes are less likely, it doesn't mean it's impossible, but less likely to have positive outcomes in drug and alcohol treatment. So they launched something where they just added to an assessment because they realized we've never even asked if people want to quit smoking. So they introduced a strategy when people are in drug and alcohol treatment programs in the early 2000s. They would ask, are you also a smoker, when they did their drug and alcohol history, and simply ask, would you like to learn how to stop while you're here? And that's it. And they found a lot of individuals answered yes. They'd never been asked before if they would like to stop smoking while they're in drug and alcohol treatment. So it opened that door to do the drug replacement therapy, the Nicorette therapy, that ordinarily wouldn't have been done because we didn't ask. There was almost this assumption that people in drug and alcohol treatment smoke. I remember when cigarettes were used as an incentive to help people follow rules in residential treatment programs, where smoke breaks were given regularly in drug and alcohol treatment programs, and we never even asked if people would like an opportunity to stop. So the components are, there's a screening, and this is the healthcare professional assesses a patient for risky substance use behaviors. This can be done with a standardized screening tool. Some screening tools are a lot more sophisticated than others. I'm going to go into the NIDA quick screen, which is something that you could just remember off the top of your head and ask the question. This could be something as sophisticated as the addiction severity index, but that's not going to be able to take place in your session. That would be something that they would probably have to complete out in the lobby. Then after we do the screening, just a very brief intervention. And this could be brief motivational interview, awareness raising, just asking a couple open-ended questions of, have you ever considered stopping? If you did, would you like me to give you a referral? And this could be done in a family practitioner's office. This could be done in an emergency department. These kind of conversations can happen anywhere. But with SBIRT, we want to at least do a brief assessment, a brief screening, and ask them, would you like help quitting using? And then referral of treatment. We can't assume that somebody knows where those resources are. So we make a formal referral. That might even be giving a list of names and phone numbers of places in the community. SBIRT doesn't get into necessarily the warm handoffs or make a deliberate referral in as much as, unless somebody wants it, but we have the conversation and let them know where the resources are. There's an aggregate value where if somebody goes to an emergency room 3 or 4 times a year for an alcohol-related injury or accident, maybe it's that 4th time that they really are willing to follow through with that recommendation. So if this happens regularly in medical sessions, it does increase a person's willingness to attend to treatment. So a quick flow chart is, we do the screening, the audit, the craft, the NIDA quick screen that I'll show you in a moment. Again, these could be done in the lobby. These could be done in the emergency room waiting area. These could be done in any number of places. I know in my primary care physician is involved in a large Northeast Ohio healthcare system. And once or twice a year, that healthcare system has them all do screenings, whether it's for depression, whether it's through substance abuse, whether it's through domestic violence. But they have a process in place where periodically everybody that comes through the lobby that month does one of these screenings. And if it's positive, they just inquire about it. Now, if somebody screens and there's clearly no problem, a negative screen, we just reinforce their positive choices. If there's a positive screen, the next step is to assess, is there a level of concern here? Is there an overdose risk? Is there a drug interaction risk? Is there a withdrawal risk? And if there's high concern, the clinician would go into a brief motivational interviewing strategy and make a formal referral. If there's a moderate concern, to again do a brief motivational interviewing strategy with a referral. But the bottom line is, we do the screening. Negative, we reinforce good choices. Positive, determine a level of risk. And if there's moderate concern or above, enter into a brief conversation about it and offer them some materials for referral. Now, the NIDA quick screen, again, if you do this once or twice, you'll just remember it. We don't need to break out the paperwork every time, but in the last year, have you used any number of substances and just never once a week, monthly, or weekly? And that's pretty much it. We don't need to even go by drug all the way down a list. You know, over the last year, how often have you used mood altering substances? Never. Once or twice, monthly or weekly, or, you know, daily. And this is just enough to kind of get a brief determination if we might want to inquire more deeply. This will also give you in this slide, and you will all have access to the slides, a little bit of guidance and links of what to do when somebody scores positive on this. Now, this is a public domain, so we don't have to worry about copyright infringement or anything with the NIDA quick screen. And most of the screening tools that I talk about, whether it's for mental health or addiction, I usually go for the public domain models. Not that I don't love what Aaron Beck has done for the depression and counseling and cognitive therapy, but good God, the BDI is still copyrighted. And so let's just go with the PHQ-9. So the brief intervention. BNI, if you look through literature, is how it's usually referred, but it helps healthcare providers really explore behavioral change in a non-judgmental way in a finite time period. And that's really what had to be addressed with primary healthcare. You know, I'm a mental health therapist. I usually have 50 minutes to an hour with a patient. You know, an emergency department physician has nowhere near that. You know, even a family physician has nowhere near that. So it has to be quick, non-judgmental, and really designed for action steps with a patient. It does have some foundations in motivational interviewing, but you don't need to be a motivational interviewing expert to provide a brief negotiated interview. You know, there's a couple models for it, but it's basically semi-structured interview process. Semi-structured means you bring your personality to the table. Semi-structured means it's fairly casual type of conversation. And those kind of conversations resonate well with patients. You know, personality matters with patients. There might be 3 physicians that suggest a patient do the same exact thing, but the patient is most likely to follow the guidance given to the physician that they feel they trust or bond with the most. So how you deliver these questions is always important. And I know William Miller, the developer of motivational interviewing, refers to that as the spirit of motivational interviewing. Now I'm going to do, and I apologize in a way for this, but after I apologized the first time, I'm about to show you 2 very low quality, poorly acted vignettes of emergency room doctors having a brief interview with a patient on substance abuse. Now, I had usually really apologized because these are, I'm telling you, they're really poorly acted vignettes. But what I have learned is by the time medical students are in their 4th year, they have had a lot of poorly acted vignettes where it's pretty much the norm. So I guess this isn't going to be that much of an outlier for a lot of folks. So let me go into these real quick. Let everybody see all the garbage on my desktop. So the first one is how not to do a brief negotiated interview.
You had a serious car crash. You're lucky you didn't kill yourself or somebody else. What do you intend to do about that drinking problem?
What drinking problem? Look, I had a couple of beers, my friends, that's all.
Your alcohol level was 190. Clearly, you had more than a few beers. Now, how much do you really drink each day?
Look, I had a few beers with some friends of mine after work. I mean, what's the big deal? Everybody does. I mean, I work hard, and having a couple of beers helps me relax after a hard day. It's time I got a little careless. That's all. Just so let's not make a big deal out of nothing. Just finish sewing me up so I can get out of here.
Look, I'm an ER doc, and I think I know when somebody's an alcoholic. And I think you have a serious drinking problem. You better straighten it out. Now, you can get out of here as soon as I stitch you up. But in the future, do not drink and drive. Have some sense. I mean, next time you might not be so lucky.
Try this strange 10-second technique tonight to reverse.
We're not going to do the 10-second technique if that's okay. Actually, the image is kind of frightening for me as a non-physician. Now, just out of curiosity, do you guys believe that there are physicians like that?
Reverse type 2 diabetes.
Let's
Most
get
people-
the British narrator off here. Nicole is horrified.
Oh, absolutely, they exist.
So
I think
remember,
also, I would say that that doctor may have just seen, recently a terrible car accident that he's still processing. I can think of a lot of reasons why a more normal person who typically wouldn't approach it that way can end up having a reactive conversation like that based on all the stuff an ER doc sees. I'm just trying to be generous.
and you're being generous and you're being real, because physicians, like any discipline, have bad days. Physicians are busy. They are overwhelmed. COVID has shown us how overburdened the healthcare system is, and the frailty that has caused some of the, that some of the people have with that kind of stress. So we know that. We also know all patients aren't the most willing and kind when they're in these experiences. So all that holds true. But patients do remember those encounters and remember those experiences. So we're just going to go into the same scenario, and the same conversation is gone about in a different way.
You had a pretty bad crash. Do you remember what happened?
Not really. I remember leaving the bar. The rest is pretty much a blur.
So you're unable to remember your injury because of being in the bar.
Yeah, I guess so.
Sounds kind of frightening. Would you mind if we spent a few minutes talking about your drinking?
My drinking. What about it?
Well, help me understand what drinking does for you. What is it you enjoy about it?
Look, I work hard during the week, and having a drink or two after work helps me to relax. I mean, a guy that's cut loose every once in a while. And my friends go out a lot, and I like to hang out with them.
So it's a way of relaxing and enjoying being with your friends.
Yeah.
Well, I can understand that. Everybody needs to unwind. Now, are there any things that are not so good about your drinking?
Not really. I mean, I have trouble getting up some mornings. And I can't think straight for most of the morning some days.
It must make work more difficult.
Yeah, I mean, the day starts out kind of hard, but I just, stick it out. Try to push a little harder.
Sounds tough. Are there any other drawbacks to drinking?
Crashing my car is kind of a drag. I need the car. And having to get sewed up like this isn't too much fun.
No, I imagine not. We're just about finished here. And that should do it. So, on the one hand, drinking is a way for you to relax and enjoy doing it with your friends. On the other hand, it makes getting up in the morning more difficult. Wrecking your car and having to be stitched up in here, well, those are other painful consequences. So where does that leave you?
Here's how I can cut down, on the drinking a bit, especially during the week.
Yeah, I think that sounds like a terrific idea. Have you ever tried cutting back before?
Yeah, I've done it before. I can do it on my own.
You know, Joe, some people can cut back, but for some it's difficult. We find that having more than 14 drinks per week, or more than 4 drinks on any one occasion, could put you at risk for some serious problems. Not to mention injury or illness. If you find that after 4 weeks you're drinking more than that, well then, in my medical opinion, you could benefit from some outside help. I'd be glad to give you the names and numbers of people who you can speak to. Now, about your drinking and driving.
Yeah.
So what did anybody notice differently about the second emergency department experience? Anything?
Well, a lot more subtle. Worked it in conversationally.
And that's true. And what this slide is this was created by the Pennsylvania Department of Health. And it's just a brief card that they distributed to a lot of the hospitals, to a lot of the emergency departments, just to give somebody kind of a quick and easy card for how to conduct a brief negotiated interview. And even in that little 3 minutes, what we saw the second physician start with was just a brief general conversation. And it could be as simple as, looks like you had a bad day, or, just anything to break that ice and start that conversation. But with a brief negotiated interview or motivational interviewing, we want to ask for permission to talk. We want to ask for permission to offer guidance or advice. Would you like to hear my thoughts on this? I have a couple of concerns. Would you care to hear them? And if they say no, we don't, because they're not going to be listening anyway. But 9 times out of 10, when we ask somebody if they would like to hear our thoughts on this or our concerns, they will give permission. And that just small level of permission that they give sets them up to be able to listen a little bit more intently. Explore the pros and cons. What are some good things about using? What are some not so good things about using? We want to build that discrepancy, to give somebody something to think about. We don't necessarily want to answer those questions for them. If you've ever gone to a movie that ended suddenly and badly, the chances are you continue to think about it, because if all the loose ends aren't tied on or aren't tied up, we keep thinking about things because our mind really wants to find closure. So when we leave these pros and cons open for when they walk away, that will be something that they continue to think about. Ask open-ended questions, reflect, which is where that you put in your insights is into your reflections. Ask permission to give information, any findings that you have, even findings like a blood tox. If somebody comes in with a blood alcohol level of, say, 0.08, and they are slurring their words, that there's likely that this person doesn't have a high tolerance. This person isn't somebody that regularly uses. But if you have somebody that comes in with a blood alcohol content of say 0.29, and they're combative and they're still driving a car and this is somebody that has drank to the point where they have a pretty high tolerance. So sometimes I would even look at a BAC, and somebody that has a high BAC that's telling me that they only had 2 beers. I have an idea that it's more than that. So you could discuss findings. Like the substance use, to any consequences, can we talk for a couple minutes about this? And again, we ask, I'd like to talk about this for a couple minutes. Is that something you're willing to do? And if they say yes, they're going to be more involved in both the conversation and the solution. Something that is used commonly in motivational interviewing is something called the readiness ruler. And this would be, you would just ask the individual that you're with, and it could take, you could do this entire thing in less than 30 or 40 seconds. On a scale of 1 to 10, how important is it that you slow down your drinking, or that you take a serious look at your drinking, or that you stop your drinking? So on a scale of 1 to 10, how important it is. And they might say, oh, it's not that important, maybe a 3. Your next question is, why didn't they choose a lower number? So why not, well, 3, that's pretty interesting, but why not a 1? And it puts them in a position to really start asking themselves, it seems like part of me really does want to quit drinking. It seems that part of me does think this is important. And negotiate a plan like the second physician. Either, I'm thinking about, trying to quit, and leave it at that. Or here's some referrals if you find you struggle with it, and leave it at that. But it's a brief negotiated interview, and oftentimes just let them go. With my physician, I've been sober for 37 years, and he does recovery checkups with me. And it's really important to me, and it's one of the reasons I like him. And he says, if you were diabetic, I'd be checking your blood work regularly and asking you about your diet. And I'm 37 years clean and sober. And when I go in to see him once a year, he'll ask me, so how you doing with that? Are you still going to the meetings? He checks in. And that's another way to start a conversation, because over this last 37 years, there's been times I struggled. And that little ask opens the door for me to have honest conversations with him. So I'm not going to go in anymore to this. The rest of this is really just some samples of motivational interviewing. It gives you some responses that you can have, some examples of reflections, complex reflections, summarize, how to summarize, and some resources on the back end. So you get the PowerPoint. Feel free to go to these resources. There's also examples of a lot more of these interviews of how to and how not to. Motivational interviewing has its own YouTube channel now that has a variety of scenarios of poorly acted vignettes to give you an idea, at least, of how to get into these conversations.